pleasant good morning to the print and electronic media. Special welcome to my director on my left, and Director Alicia Batiste. Director Batiste is a member of the Millennium Heights Medical Complex board. She's also the deputy chairperson of our Staffing and Compensation Committee. So this morning we have a very informal session to meet with the media as a key stakeholder in the development of the services here at the Millennium Heights Medical Complex. Our board has taken the position that we need to expand our outreach program to civil society and the NGO community. You'll recall that late last year we had 3 successful town hall meetings at Grosselet, Castries, and Bavano. And these meetings were really part of the board's trust towards engaging the public in a meaningful way to support the development of the Millennium Heights Medical Complex. We don't have all the answers to solve the problems of this facility, so we rely on civil society, NGOs, and the media representing the conscience and voice at times of the public to be part of this. So this morning we have invited the print and electronic media to a breakfast meeting to start by sharing with you who or what we are as a complex. And then we will have a guided tour in selected areas across the hospital. This is a big, the footprint here is fairly big, and it's going to take at least a full day to be able to walk all the facilities. So we've chosen selected areas that you will get a good flavor of what this complex is about. And through your type of market reach, use that data to project to the population of Saint Lucia what the complex is about. We have, our board values transparency and openness in the way we conduct our business. We've been very open and transparent with the media over the last 12, 18 months, and will continue to be that way. So that is all I really want to say this morning, and I want to ask my director, she wants to say a few words, and then I'll just give you a short presentation, and then my communications executive will take it over from there.
Good morning, all.
Good morning.
We welcome the media at all times to our facility, and we look forward to having a very productive relationship with the media. As a board, we always look forward to have this transparency with the public and to ensure at all times that quality care is given at this institution. So again, we say welcome.
Who we are as a Millennium Heights Medical Complex. Hospital services at a glance, some of our key challenges. Have a little discussion around the accident and emergency department, development of our secondary care hospital, and our focus for 24-25. Let me just say at the outset, governance is about accountability, but as our director has said, good governance is the art of public leadership. And today really is testimony to this question of good governance, in that we want to be as open as we possibly can to our various publics, including the media. So, who we are as a complex, the OKEU Hospital is the flagship facility and the prime real estate here within the complex. It comprises 122 beds. There's a national mental wellness facility of 103 beds, and at Turning Point Rehabilitation Center comprising 8 beds. We provide 24-hour emergency and inpatient services, general and surgical subspecialty, supported by a number of operating theaters. General specialized area, internal medicine, general surgery, pediatrics, obstetrics, and gynae. We also provide subspecialty in intensive care, laboratory, and pathology services. So it's a fairly robust tertiary care facility. This is not secondary care, this is a tertiary care facility. As you know, we've just taken over the management of the secondary care hospital at the former respiratory hospital. That is going well. We've commissioned 12 beds last December. We're now remediating the remaining wards to make it a full-fledged secondary care hospital. It will have dispensing facilities, 3 ICUs, 2 operating theaters, a pharmacy, and of course, imaging studies for routine X-ray and ultrasounds, or sonography. The next few slides will speak about our throughput. This is a did you know moment. We admit over 6,000 patients a year at this facility. We see at least 15,000 patients in our outpatient clinic. Our A&E department admits over 18,000 patients a year. We conduct about 1,900 surgeries, and we have about 94 patients on hemodialysis today. In terms of imaging studies done, the annual throughput is about 19,000 images per year. Laboratory in all areas in the lab, just over 500,000 tests done. We fill about 15,000 prescriptions a year and provide about 15,000 physiotherapy treatments. This is by no means a small facility. It is an extremely busy plant. We oftentimes hear comments in the public about the level of satisfaction or dissatisfaction with our services. We measure on a daily basis the happiness factor of all our inpatients, outpatients, and patients coming through the emergency department. As of December, we've interviewed at least 4,800 patients who've been discharged. And this is what they've said. We didn't say it, this is what they have said. Because we asked them some questions, we fill it out on a tablet, they validate it, it goes into a business intelligence software, and we get data on how our constituents see the Millennium Heights Medical Complex. As of December, 3.8 out of 5, we got a 3.8 out of 5 score in terms of satisfaction with the level of service across all the 3 areas. There's a 79% of the incumbents who satisfied with the level of service. But one of the areas that we measure a lot is what we call this Net Promoter Score. And that is the extent to which our publics will promote the Millennium Heights Medical Complex as a place to receive care, as opposed to persons who will say, don't go to that facility for care. And we're about 52%. In other words, half the persons that we've interviewed said they will recommend the Millennium Heights Medical Complex to their relatives and friends and families to receive care, and the remaining half feel indifferent about it. So this is where our work is. There's a high level of satisfaction with the services, but to promote the hospital to your friends, families, and others, there seems to be some level of indifference where that is concerned. So we have a lot of work to do there. Many times when persons complain about a good or bad experience, it's about waiting times generally. It's about the level of interaction between our doctors and our nurses. So we have a lot of work to do in that area to be able to move it forward. But generally, you don't oftentimes hear about quality of care issues in the main. And perhaps that's why our satisfaction rate is maybe at 79%. So we have to work on this area of the Net Promoter Score and the ability or the consideration for those who receive care to be able to promote the goodwill of the institution. We do have a complaints mechanism in place, and we want to hear from our publics, the good, the bad, and the ugly. Where things have gone well, we want to hear from you. Where things haven't gone so well, we also want to hear from you, so that we could take steps to improve what we do. You oftentimes talk about the 4 C's: concerns, clarifications, complaints, and commendations. The 4 C's: concerns, clarifications, commendations, and complaints. Let's be balanced as to how you see the service. I like this, I enjoy this service, good outcomes, but you want to hear the but as well. Because it is when the public, including the media, provide that feedback to us, we're able to take corrective actions. Not in a defensive way. My director will tell you here, it's not a defensive way at all. We want to hear the concerns of the public so we can make this thing better. So the more you're able to give us the feedback, the unadulterated feedback, the truth and only the truth, we are comfortable with it. This is not a board or management that is thin-skinned. This is why we feel open and we could face the media. Where we've come good, we'll tell you we've come good. But where you haven't come so good, we'll say we haven't come good. But we'll also say to you what steps we're taking to correct it and to make things better. In terms of our profile and the cost, the package of services that we currently provide is estimated to cost close to $90 million, believe it or not. This is why the media and civil society must have a say in which the taxpayers' dollars are spent. $90 million is a lot of money for one institution, and therefore we require you to be able to give us your feedback on ways in which we could improve what we do here. Be critical, yes, but provide constructive criticisms as to how we're going to make life different here. What are our challenges? Well, the first is bed occupancy. We have a serious problem with bed management. We moved from 150 beds at the former Victoria Hospital to now we have here at OKUH 120 beds. So if you go to our emergency room, as you would see in a while, there are on average about 25 patients who have been seen and cleared for admissions, but we have no beds. Some patients stay there maybe 5-6 days and then they're discharged from the emergency department. So the transfer of facilities to allow us to set up a secondary care facility would be not the panacea for solving it, but certainly is going to help give us some additional beds so we can move patients from our A&E department and on the wards across to the secondary care facility. Care provided in the wrong setting is yet another challenge. Close to 20 to 25% of the patients who present here are really more better served on the primary care network. But when they present our emergency room, we have to see them. Right? And these are the ones who would stay the 3 and the 4 hours and then complain down the road. It's a kind of love-hate relationship. They love it because they've stayed the 4 hours, they saw the doctor, they got the diagnostics, and they're well and they leave. But they hate it because they've had to stay for 4 hours. Right? When really these patients should be at our primary care network. Because when they come to our hospital and the emergency department and we have to divert resources to take care of them, it then prevents our staff from now taking care of the critically ill patients in the back. So we are really asking the public to utilize your primary care network for primary medical conditions. We have seen within recent times a high level of no-shows for appointments at our outpatient clinics. This creates a waste of resources for us. We call patients 48 hours before their appointments. They've confirmed that they're going to show up, and then we still see this high level of no-shows. Almost 30% of the patients that have bookings or appointments at our outpatient clinics don't show up. It's a high number. So we asking the population to, where on occasion you're not able to make your appointments, that you must try and notify us earliest so we can either rebook someone else in your space and or rebook your appointments. So no-shows turn out to be a fairly challenge for us. Our public health system today faces the challenge of this resource gap between what I refer to as the demand for and cost of health services and the supply of resources. It creates this gap. How do we therefore maintain or narrow the gap is one of the bigger challenges that we have. And what is driving that gap? The disease and health profile. It is no secret that the NCDs is with us. It's an epidemic in the country. We have a high incidence of NCDs. We have the emergence of communicable diseases like we now have emerging itself, COVID. The vexing issue of injuries from accidents and violence. It's a public health crisis. And therefore, when these resources present to our doorsteps, we have to take care of them. Many of them require surgery, many of them have to go to ICUs, and many of them live with disabilities, and therefore now pose a burden on the social safety net of the country. So the disease and health profile is one of the areas that is driving this whole question of the cost of healthcare services. There's some factors that I refer to as exogenous factors. And these are factors that are outside our control. The rising cost of drugs and medical supplies. We in this part of the world do not control the cost of drugs and medical supplies. Whatever the market says it is, we have to accept the price. And almost every month when we receive an invoice for drugs and medical supply, they're all increasing by 10 cents, 15 cents, 25%, 25 cents. Advancing technology. We are required to keep the plant in a good state of repair and make sure that we have a modern plant befitting of a tertiary care facility. This requires capital to be able to change our equipment every 4 or 5 years' time. So technology and technology refresh is one of those areas that we have to address. There are, of course, systemic factors that we have to address as well. Waste and inefficiency. Malpractice coverage, which is a function of the highly litigious environment that we're in today. Today, we spend close to $600,000 a year in malpractice insurance. And it is not discretionary. We have to, because things can go wrong. And if a suit is brought against us, we have to be able to cover it. One particular line item, malpractice insurance, costs us just over $600,000 a year. Medication errors, adverse incidents, care provided in the wrong setting, are all those factors systemic factors that are driving our costs. There are, of course, other contributions. We have a population that is traveling and they get in care in Martinique and elsewhere. And they all see all the fancy gadgets and the technologies and are coming back to us and saying, well, you have to get with it. So there's high public expectations around what they perceive a tertiary care hospital should be and should look like and feel like, having gone to the metropolitan countries and even right within the region to see what these facilities provide. So those are some of the challenges driving this gap between the demand for the cost of services and what the supply side is. The government could only provide so much resources. And therefore, if we don't find a way of dampening the cost side of it and the demand side of it, then we're going to have an unsustainable program. Our board laud the effort of the government in beginning at the process of universal health coverage, because embodied in that overall program, it means every citizen, the rich, the poor, the young and the old, the employed and the unemployed, all will have an opportunity to receive a basic package of care without enduring financial hardship. So the government has started a phased approach through the maternal and child health program and through the performance-based financing program. But embodied in all of that will be the whole question of healthcare financing. And we hope that with the introduction now of the health and security levy, that some of those funds will filter back into the health system to provide a more sustainable package and program for the people of St. Lucia. Let me now turn to the accident emergency department. This is the face of the hospital, and my director will tell you it attends our board at every single meeting since I'm on board. There's always an agenda item to speak to what are we doing to improve the accident emergency department. I'm here to say to you today that over the last year, we have shown demonstrated noticeable improvements in care to non-urgent patient presenting for non-urgent care. And that is persons who walk in, not persons who come in with ambulances or by motor vehicle, but these are persons who walk in for various types of primary medical conditions. Today, we triage these patients or sort these patients for a more colloquial term within 45 minutes. So from the time you walk into A&E to the time you see a triage nurse, we average about 45 minutes for category 3 and 4 patients. And these are patients who are presenting for non-emergency care. For patients who come by ambulance, of course, we see them right away. There's really no waiting time. We see those patients right away. So we're happy to celebrate that we've seen some improvements in wait times for the non-urgent care. Door to disposition, meaning by the time, from the time you come into the A&E to the time you see a doctor and he disposes of you, running about an hour to an hour and a half. We have an improvement project that is on the table now, and we'll expect to roll that out within another 2 months, hopefully by the end of March, where we're creating a reception area to meet and greet persons who come into the emergency room. We'll be using our emergency medical technicians to do what we refer to as first triage. So they're going to quickly register you, and then you move straight in to see the nurse. So we're finding ways to reduce the wait times of patients presenting in our emergency room so as to better serve the public. But again, we're saying to the public, patients who require non-emergency care should really seek care at the compendium of health facilities at the primary care level before coming to the Millennium Heights Medical Complex or the OKUH. Because whenever you present there, while we have to take care of you, we're forced to now divert resources to take care of you when we have other more deserving, life-threatening circumstances waiting for care. I mentioned earlier on, we call them boarded patients. We have at least 25 patients every day in our emergency room. Last year, the numbers went up to as high as 45 to 45, I think, in one instance. So the setting up of the secondary care facility will certainly provide an escape valve to allow us to now move some of these patients into a different facility. It is not for poor people. It is just a different level of care within the overall continuum of care at the complex. So I mentioned earlier on that the secondary care hospital is built around, is part of a Castries multipurpose medical facility driven out of our Ministry of Health. They are going to manage the Castries Urban Polyclinic. They are going to manage the Castries Urgent Center, which is a facility that will open from 8 to midnight, providing urgent care to the population. And the Millennium Heights Medical Complex will manage the secondary care hospital. This facility will have about 31 beds, 3 ICUs, 2 operating theaters, satellite laboratory, dispensing, a pharmacy, and we will also have imaging studies, plain X-ray and ultrasound. We'll continue to manage the chest wing, comprising 10 beds and 2 ICUs. But the important feature there is that our board is at an advanced stage of putting in place regulations for what we call admitting privileges. And what those regulations would allow is for doctors in the private sector and elsewhere to pay to use our theaters and operate on patients privately. So these privileges will therefore expand capacity in the country, in that doctors will now have options for the use of a safe theater. Patients now will have accessibility to care, and feel very proud of it, because in so doing we could serve as the barometer for keeping healthcare costs down. This is not about profit for us. It's not a profit-making venture. Certainly, yes, we'll make some revenue for it, but our motive is a much more noble motive, because we want to get to a stage where every single citizen, if they so desire to exercise the choice for private care, must be able to access that care at a reasonable cost. And part of that cost, in terms of our contribution towards it, is coming up with a safe theater, safe ICUs, safe recovery room, modern theater, state-of-the-art, that they can operate and follow the patient post-operatively. This will expand capacity in the country and therefore provide a more robust infrastructure for care to our population. So last night we sort of refreshed the areas, and the 2 areas that are on the table and is likely to kick in sometime in April this year is the development of minimal invasive surgery in selected areas. South Korea sees they operate about 180 patients a day in minimal invasive surgery. So could you imagine if we send our surgeons there, they could work from 8 o'clock in the morning right back to the night. So that's an area that we're seeking to develop expertise here, minimal invasive surgery. We're very much interested in setting up our EICU, which would allow our intensivists here at the OKUAs to be able to monitor patients at the secondary care hospital and St. Jude's. This is an area we've seen develop in South Korea, and it's an area that will help us develop. We're pretty much interested in digital health as part of empowering patients to take responsibilities for their care. Very shortly, we'll be launching a couple people-centered care initiatives here at the hospital by adopting and adapting what we see in South Korea. We've discussed with them the areas around improving our leadership and governance, so we could send out some of our managers to spend some time and see how another hospital, another health system functions in terms of managing hospitals. So yes, it is very much alive. We had that meeting last night, and I believe on or before April this year, 2 of those areas will bear fruit. Some of it we've already taken on board, and we're seeking to roll that out piecemeal. In another 2 weeks, we have a health promotional theme that we will roll out here at the hospital, and the media will hear something more about it. Because with NCDs that is so pervasive, there's no longer the territorial barrier for health promotion. Why can't we do health promotion here within our hospital setting? Wherever we have spaces with gathering persons, why can't our nutritionists go and speak to patients about diabetes, hypertension, and cancers, etc.? So we are going to be launching a program towards the end of March to begin health promotion in a big way within our hospital. And this is one of what we've seen in South Korea. There are rooms like this where persons are invited and they taught about portion control, good eating habits, what constitutes a balanced diet. And there's no reason why we cannot adopt and adapt that within our setting. So we've challenged our nutrition department to work towards that, and we hope to launch that program towards the end of March. Yeah.
Mr. James, you mentioned that the hospital spends close to $600,000 on malpractice insurance. Is that annually?
Yes.
Yes?
Yeah.
Okay, I'm curious. How do you deal with cases where nurses and doctors are accused of negligence? Dale Elliott did a documentary on a patient not too long ago. I can't recall his name, however, that patient developed bed sores over a period of time, and he developed some really nasty infections, and he died. In a case like that, where nurses and doctors are accused of not giving the patient the best care, how do you respond to that situation?
Well, the adjective you use there is accused. And we must take that guardedly. I've seen the Leonard story. He's interviewed me, and I shared with him, our views around it. Sometimes we believe that healthcare workers are not infallible. They're all humans like you and I. This is why we have to purchase malpractice insurance to protect the institution. But let me just say, when incidents take place at the hospital, these incidents are logged, the investigations are executed, are carried out, and these investigations are not carried out by persons who are involved in the crime scene. These investigations are conducted by a quality department, usually by a risk officer, and they're required to conduct what is called root cause analysis, so we know what the truth is. Coming out of that, a decision now is taken as to were we liable or not. Where we are liable, we say to the public, look, we didn't do as well as we really should be, and this is what we're doing to improve it. Some persons go on the literature side, and we ask our attorneys to just sort that out, accept liability, and let's see how we could settle out of court. In cases where our investigation prove otherwise, we're prepared to defend it. So whether you decide to take litigious action or not, we will defend it. Now, that cannot be a self-serving arrangement, because if it goes to court, the institution will look silly if we don't. So this has to be an independent kind of work that transcends whether you're an employee or otherwise. Because at the end of the day, we could be called to be an expert witness or witness in court, and therefore the facts of the incident must stand on its own. So we're not fearful of it. So we are trying to create what is called a just culture by saying to staff, things can go wrong. When it does happen, don't be fearful, report it. Because when you report it, we could then take the appropriate action to prevent it from becoming a catastrophic care. The analogy I use, you have a tap at home. You know the washer is bad, but it's just dripping. It's just dripping. And then one day you go home and it's flooded. But what we say that those dripping taps are what we call near misses. And when they happen, we want our staff and the public to let us know so we can mitigate it. Because if we don't, it escalates now into a catastrophic situation. So how I will answer you is that we're seeking to develop a just culture, which means that staff should feel comfortable reporting any incidents that happen. We would rate the incidents as to whether we believe it will cause grave harm or injury or death to the patient. And we do what is called a root cause analysis. Those that are near misses are the dripping taps that we seek to correct immediately. But those that are likely to cause or have caused death or catastrophic outcomes, we must do the root cause analysis. So that is the kind of framework within which we operate, our incident management framework. We've adopted the ISO 31000 as our framework for risk management, and within that framework, it describes and defines how one will identify, assess, control, and report risk. So this is not guesswork. We're using the International Standards Organization, ISO 31000, as the framework for risk management. As you know, central procurement is the national procurement agency for drugs and medical supply for the entire public health system. Right? They hold the budget. So there are times when their relationship with suppliers run into problems. When that happens, it means the entire public health system is compromised. So what our board tactically has put in place is that, limited as our resources are, we use some of those resources to purchase what we call the vital, essential, and necessary drugs to have on hand. Our game is to have at least 3 months supply on hand. We haven't gotten there yet. So that when on occasion central procurement is not able to meet the requirements, we have some stocks to carry. So we've quietly opened back our outpatient clinic that has been closed for almost over a year. So patients are now able to go to our pharmacy and get prescriptions filled quietly. We haven't promoted it or advertised it because we wanted to do a very soft and easy launch to see to what extent this approach we've taken is bearing fruit. We started in somewhere around July last year. We were seeing about 600 prescriptions in July. By December, it has gone up to nearly 2,500 prescriptions. So patients are using the facility in an outpatient setting. Are we where we want to be at this point in time? Certainly not, right? But we feel encouraged that we've seen some improvements in the supply of drugs and medical supply demand to treat patients. We do in fact experience stockouts like all health systems over the world, but we try to strengthen our materials management process by having supply chains across the facility within Saint Lucia and outside of Saint Lucia. So we try to manage those relationships as best as we possibly can. But yes, that question of materials management is a challenge for all public health systems, but we are trying to find very creative ways of navigating the waters. So we've completed the trust deed. It's completed. It's before our board now. And our board is now identifying trustees to be part of that trust. I anticipate that perhaps by April, we should be ready to roll that out. This MHMC trust is a special purpose vehicle for raising philanthropic contributions to meet capital expenditure and improvements, and to support the planned replacement of technology when or if they become obsolete. This is very innovative in our public health system because we recognize the fact that the government of the day cannot provide all the resources, and these are all the capital resources, to meet the needs of this facility. If we are to sustain this facility as a truly developed tertiary care facility, then we need to invest in state-of-the-art. And so through this mechanism, we can then attract funds from corporate St. Lucia and the diaspora, and even the civil society. So we're really looking forward to it. We committed to raise $1 million in the first year of operation. So once we're able to launch it in April with the trustees, they will be given a prospectus and they would go out there and try to raise funds. Ideally, this black tie event would have formed part of their work program, so to speak. But we're not waiting. We're pressing on to look at ways in which we could address it.